So hi everyone, my name is Sarah Isinga and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And I'm pleased to welcome all of you to today's conference session on follicular lymphoma. We appreciate those that are able to attend live today to learn more about the disease-specific biology and diagnosis of this lymphoma subtype. This presentation will also highlight novel research and treatment options that are accessible to lymphoma patients across Canada. Now, before I introduce today's speaker, I'd like to provide some guidance about the Zoom software for this session. This virtual software does not allow you to share your video or your microphone. If you have a question, please save it for the indolent non-Hodgkin's lymphoma Q&A session following this presentation. This is where you can ask your questions to the presenter live. I would now like to introduce and welcome you to our speaker, Dr. Michael Crump. Michael Crump is a hematologist in the Division of Medical Oncology and Hematology at the Princess Margaret Cancer Centre and Professor of Medicine at the University of Toronto. His clinical and research interests are primary and secondary line of therapies of lymphoid malignancies, investigation of novel therapies, and in autologous stem cell transplantation. He is currently the co-chair of Hematology Disease Site Group and the Lymphoma Working Group Chair for the Canadian Cancer Trials Group. Thank you very much for joining us today, and now you can go ahead and start your presentation.
Hello everyone. Thank you for joining me, and I look forward to the Q&A session that's going to happen after this presentation. So I'm going to cover follicular lymphoma diagnosis and treatment. So this is basically the things I'm going to speak to you about today. Some general things about lymphoma, and in particular follicular lymphoma, because that's what I know what you're interested in. Some brief comments on the pathology, but mostly information about treatment for follicular lymphoma, focusing on initial therapy. I'll briefly describe some of my thoughts about second-line treatment and provide some inspiration about new things that are happening, and hopefully be able to answer your questions at the end. So, as you're probably aware, but maybe you weren't, there's more than 50 different kinds of lymphoma. So treatment will depend on what kind of lymphoma a person has, where it is, how much of it. So those are the terms that we use to describe stage or bulk. And then, how well is the person with the lymphoma? How old are they? What's their general health like? How significant are any associated medical problems that they may have with regard to impact on either the treatment or the outcome of the treatment? So it's a disturbing term, but lymphomas are divided into aggressive and indolent lymphomas. Those with aggressive lymphoma may have a shorter onset of symptoms, so they feel well 1 month and they have quite a lot going on in their lives the next month. These lymphomas often present in places that are not really lymph nodes, so arising in the stomach or the sinuses or the thyroid gland. In aggressive lymphoma, the goal that we talk about mostly with patients is to cure, to make it go away completely, never come back. And that's accomplished with chemotherapy, with or without radiation. But as I'll show you, maybe it's not always so bad to have a lymphoma that's not considered to be curable. Most of these are B-cell lymphomas, and some are T-cell lymphoma. Indolent lymphoma is what is going to be the focus of our discussion today, although you'll see why I mentioned aggressive lymphoma as the talk goes on. So these lymphomas have a much longer natural history. Remissions can be achieved after treatment, but relapses often follow after that, sometimes many times over the course of the natural history of these lymphomas. So response to treatment is generally seen, but remissions become shorter with this passage of time. Nearly all of the lymphomas that we treat are B-cell lymphomas. So what is follicular lymphoma? Well, on the left-hand side of this screen, you can see a picture of what a normal lymph node looks like. If you're a pathologist and you look down the microscope at a section of through a normal lymph node taken out from the neck, or for that matter from the tonsil, you would see these things called lymphoid follicles. That's the business end of our immune system. That's where our immune system, the cells of our immune system, learn how to recognize foreign invaders like bacteria, viruses, etc. So they're important parts of our immune system. something happens inside these lymphoid follicles, or maybe in the bone marrow where lymphocytes live, and that's this translocation shown at the bottom on the left-hand side, a translocation of a little piece of a chromosome on chromosome 18 gets added to the bottom of chromosome 14, and it turns on a gene called BCL2. So BCL2 actually immortalizes cells, not just lymphoma cells, but other cancer cells as well. And so these immortalized cells start to accumulate in these follicles, and they create something that looks like this on the right-hand side. Now the follicles are not full of cells trying to fight off germs and viruses, but are also full of malignant cells, and those cells result in the expansion of lymph nodes. That's why lymph nodes become enlarged and grow and cause symptoms. It's not all just about the size of the lymph nodes, and it's not all about this one chromosomal translocation. The little panel at the top shows that there's a whole bunch of other genes that become mutated in patients' lymph node samples in follicular lymphoma, genes that are important in regulation of cell processes like dividing and metastasizing to other parts of the body. But this is where follicular lymphoma arises from. So these are US data looking at different lymphoma subtypes according to the most recent classification by the World Health Organization of lymphoma diagnoses. So you can see that about 12% of everybody with lymphoma in the US, and the Canadian population is very similar, out of all of the patients with lymphoma, about 12% will have follicular lymphoma. So it's a relatively common subtype, and it is the most common of the indolent lymphomas that we see in our practice. So what about Canadian statistics? Well, there was a recent analysis that looked at cancer registries across Canada that shows that the incidence of this lymphoma amongst Canadians is about 38 cases per million. The mortality rate is much lower at 1 person per million per year. So there's a lot of lymphoma survivors out there, people who've been through treatment or are living with follicular lymphoma today. The incidence of this lymphoma, unlike most other kinds of lymphomas, is actually pretty similar between men and women. In almost all lymphomas, in particular aggressive lymphomas, men have about twice as high an incidence compared to women. The average age is about 60, and this is a lymphoma that's very uncommon in people under the age of 40, only about 10%. So who's at risk of getting this lymphoma? I have to say that often when people ask me that in clinic, I just tell them that I don't know. And that's to say that there's no really strong single risk factor for this. It's not a lymphoma that arises, say, in patients with who are immunosuppressed because of HIV or because of organ transplantation. Those are usually aggressive lymphomas. There's a bit of data about exposure to different chemicals, in particular organophosphate pesticides. So farm workers or people in rural areas where those exposures might take place have a higher incidence. A disturbing reality is that hair dye definitely is associated with developing lymphoma, all kinds of lymphomas. But this was recognized a long time ago, so the data around hair dye are really about the products that were available prior to about 1980 to 1990. And current hair dyes are not felt to impart that risk. Smoking is important in this type of lymphoma, although there's data that are a bit contradictory, and the more recent analyses show that smoking increases a person's risk of developing follicular lymphoma by about 40% compared to non-smokers, and it seems to be consistent along when people started, how many pack years they smoked, how many cigarettes per day they smoked. There's a dose response effect with regard to developing follicular lymphoma. And what's interesting is that chromosome translocation that I showed you at the beginning is actually present, can be present in the lymphocytes of anybody in the population. Normal people without diagnosis of lymphoma may have these cells in their blood, and they're much more likely to be present in the blood of smokers. So that chromosome translocation really is the thing that gets the whole thing started. And smoking seems to be a trigger for the cells to turn into lymphoma eventually, at least in some people. But genetics are a little bit harder to understand. There's no consistent consistency with regard to family history. So there isn't a gene for follicular lymphoma that we know of per se. What's interesting is that there's quite a lot of variation around the world with regard to risk of this. So In sub-Saharan Africa and in many countries in Asia, follicular lymphoma is actually quite uncommon, whereas in the West and in North America, it seems to be the most common indolent lymphoma. So we don't really understand the interaction between genetics and the environment, at least with regard to this lymphoma. We don't understand it completely. But follicular lymphoma has been increasing in frequency in Canada, and these are statistics from the same paper that I mentioned earlier, that there has been a gradual rise in the rate per million people per year. It looks like the slope is quite steep, but it's only about a 40 or 50% increase in lymphoma incidence in these last 10 years. There's a lot of geographic variation in Canada, actually. So the dark colors on this map highlight areas where the provinces where the incidence of lymphoma is highest, lighter areas where it seems to be lower. So the reasons behind this are not exactly clear, but this paper highlighted again that some sort of industrial exposure might be important because using postal codes, they were able to identify regions within provinces where there was a higher incidence of lymphoma in where there's a lot of industrial land use. So exposure clearly is important. We just need to understand it a bit better. So there's a couple of definitions I want to outline that are going to be used in this talk that have to do with the effectiveness of treatment and the results that we see when we're talking about new lymphoma therapies. So response is something that's easy to understand. I guess it's the response rates are either complete, people have normalization of their imaging test like a CAT scan or a PET scan, or a partial response. And that's really the currency for new drug development. It's what gets a new drug in the door, so to speak, with regard to further development. How high was the response rate, especially in patients who've previously been through several other treatments? There's different criteria depending on whether or not a CT scan or a PET scan are used. And this thing called the DeVille score is something that has allowed nuclear medicine doctors and clinicians to agree on the effectiveness of treatment as reflected in a PET scan. So it's really a reflection of how much of the glucose uptake is left over after the treatment has been given. I'm going to show you a picture of that. The real measure, though, of the value of treatment of indolent lymphomas like follicular lymphoma is the impact on this thing called progression-free survival, which is really how long did the lymphoma stay in control, whether that was a complete response or a partial response. What was the length of time before the lymphoma started to grow again? So that's really how most studies are constructed these days, to look at progression-free survival as their main endpoint. Overall survival, of course, is really important to patients and their families and their physicians. But because indolent lymphomas are now associated with fairly long natural histories, overall survival is often not influenced by the addition of a new treatment, because the follow-up of the study when it's been reported has not been long enough. So the first thing we see to provide evidence that a new treatment is worth adopting is an improvement in progression-free survival. Overall survival effects are either harder to find or they come much later. The other definition is really about staging. We still use the Ann Arbor staging classification that was more than 50 years ago, developed actually to describe outcomes in patients with Hodgkin lymphoma. But it's really, I tell patients that the Ann Arbor stage is really about geography. It always sounds concerning to know that you have stage 4 lymphoma, but follicular lymphoma doesn't go through an orderly progression of stage 1 through to stage 4 like some other cancers might. Many patients, as we'll get to, have stage 4 disease right from the very beginning. So this is really, I tell people, this is really the geography of the lymphoma. Where in the body is it? How much lymphoma is there? And that allows us to track outcomes after treatment is finished. It's an important prognostic factor, but it's certainly not the most important. So what does determine outcome of lymphoma? Well, for sure, the type of lymphoma that a person has. Although follicular lymphoma is graded by pathologists, and there's grade 1 and 2 and 3, and people are worried if they have grade 3, that actually doesn't have as much of an impact as overall diagnosis of follicular lymphoma. Age is important, performance status, which is how unwell is a person, what are they able to do for themselves, and how much help do they need day to day, how much time do they spend out of bed, and and are they able to go to work. That has an important influence on outcomes. Extent of disease, bulk of disease are often contributing to prognosis, but as I said, not the only thing. And of course, treatment can have an impact on outcomes, and I'm going to spend the second half of my talk on that. So there is an index that's easy to use at the bedside, so to speak, that can help describe the prognosis of patients with follicular lymphoma. This is something called the FLIPI, the Follicular Lymphoma International Prognostic Index. This was created back at the beginning, at the turn of the century, so prior to modern therapies, prior to CD20 antibodies and some of the things we're going to be discussing later. But the more of these attributes that a person has at the time of presentation, number of nodal sites, stage of disease, age, and the presence of anemia, if we add up those factors, we can see that the more the factors a person has, the worse the outcomes might be in terms of overall survival at either 5 or 10 years. Remember, these are old data that you're looking at, but at least it told us that that there are some simple attributes that we can use to help define prognosis for patients. And this index is actually still used to describe outcomes of clinical trials even today, even in 2022, even though the treatments have improved a lot. So there are some simple things we can use to help in our discussions with patients with regard to expected outcomes. And the last definition, I guess, is that remission is not the same thing as cure. Remission, I tell my patients, is how you are today. This is a state of being in the present. If you're in complete remission, that means we can't find any signs of lymphoma. Blood tests are normal, imaging is normal, and most importantly, the patient feels well and has hopefully gotten over their effects of treatment. To be cured, you have to wait a really long time. You essentially have to wait for the rest of one's life, and that's a much more difficult concept in terms of how do we know a person is going to be cured? Like, what are the signs of that, and at what point can we declare that? So it does require a long period of time for us to know. So on the topic of can follicular lymphoma be cured? Can we cure any indolent lymphoma? Well, we'll talk about that at the end. So the last bit is just, I only have one slide that has a curve like this, but this is how oncologists look at data. We look at the proportion of patients who are on one of these two curves. They're called Kaplan-Meier curves, and it's really the percentage of patients over time who are either alive and in remission. That's on the y-axis, over time as measured on the x-axis. So the farther apart these curves are, if the top curve is a new treatment and the bottom curve is an old treatment, the more confident we would be that the new treatment was better, especially if the difference between these two curves was durable. If it lasts longer, if it lasts for a long time, or if indeed it gets better with time, we become much more confident that the new treatment that we're looking at is actually improving outcomes. So let's get started. What about diagnosis and staging? So we really are very aligned on our pathologists. Those of us who treat lymphoma are really only as good as our in-house pathologists in terms of helping define what kind of lymphoma our patients have. The pathologists have lots of tools that they use to make a diagnosis of lymphoma. They look down the microscope, like I showed you earlier on in my talk, to look at what the cells look like and how they're arranged. That's called morphology. Immunohistochemistry is a way of detecting proteins on the outside of lymphomas. And that's really important with regard to modern lymphoma classification. It's actually defined by the immunophenotype lymphoma cells. We're reliant more and more on molecular testing, cytogenetic testing to identify abnormal chromosome genetic profile of tumor cells. So modern pathology is incorporating really all of these things, cytogenetics, molecular testing, as well as old-fashioned morphology and immunohistochemistry. And I think I've already mentioned this, why lymphoma is important, because we have specific treatments for specific lymphoma subtypes. Even within follicular lymphoma, there are some tests that may or some subtleties in diagnosis that will help us with discussions with our patients with regard to what to expect in terms of treatment outcomes, and even in making treatment decisions themselves. So patients need biopsies that are going to be interpretable by our pathologists. And most often it's going to require removal of a lymph node, either from the neck or the groin, so that the pathologists have enough tissue to work with. You might have encountered, or somebody in your family might have encountered, having to go back for a second and hopefully not a third biopsy in order to arrive at the right diagnosis. But this is particularly important when we're concerned about changes in follicular lymphoma over time. We're going to talk a little bit about transformation and how we need adequate tissue to make that diagnosis in a person who has follicular lymphoma. There's a lot of tests that need to be done that are going to help us understand that. And we do rely on our radiologists and our surgeons to provide those biopsies for us. So all that being said, how do most people with follicular lymphoma present? Well, typically the patient may notice that they have a new lump in their neck or a swelling into the arm or in the groin. And that would be pretty typical of most people with lymphoma. And that's definitely true of follicular lymphoma. But many people that I see have this diagnosis arrived at because they were being investigated for some other problem. So a good example of that is we see a lot of patients that are referred from the emergency department. Someone goes to the emergency department with a history that sounds like a kidney stone, or they have back pain or abdominal pain that might have been appendicitis, and lo and behold, it's actually because there's lymph nodes inside the abdomen that are causing those symptoms. So a typical presentation would be a large abdominal mass or multiple enlarged lymph nodes in the abdomen of somebody who doesn't have any lymph nodes that we can feel on the outside, as it were, in their under their arm or in their groin. It's rarely because people have abnormal blood tests. We do a lot of blood tests in patients with follicular lymphoma, but they don't disclose very much in terms of diagnosis or overall burden of disease. And most people will not have these classical B symptoms. Although I already said that many patients have stage 3 and 4 disease at the time of diagnosis, they're usually unaware of it and they're not having symptoms such as fever and night sweats or weight loss. That would only happen about 10% of the time. So we ask about those things, but they're not the most prevalent at the time of diagnosis. So most people are well, in other words, when they're diagnosed with this disease, even though they may have stage 3 or 4 follicular lymphoma. So staging tests are used to define, as I said, to define the extent of lymph node or organ involvement. And we use PET scans and CT scans as a fairly standard way of evaluating all of this. PET scans in particular are important to define very precisely what the stage of a patient if we're considering using radiation as the initial treatment. A bone marrow biopsy is sometimes done, especially if patients have abnormal blood counts. But I would say it's only in the patients that are being considered to receive local radiotherapy for presumed limited stage disease that require a bone marrow tested diagnosis. Other blood tests are done to provide some supportive information about prognosis. I mentioned LDH, lactate dehydrogenase, is an enzyme that's made by many tissues, but is elevated in some patients with lymphoma. We measure blood counts as a reflection of maybe what's happening in the bone marrow. And then liver and kidney tests to make sure there's no impact of enlarged lymph nodes on kidney function or liver function. And everybody who's going to get chemotherapy these days needs testing for hepatitis B exposure or infection because of the possibility of hepatitis reactivation during treatment. So this is these are some images of what a PET scan looks like. On the left-hand side, you can see there's a lot of gray smudges in various parts of the body, in the spleen and in the liver. That's what these lumps are down here, in the spine and in these lymph nodes in many different places. And after treatment, what we want is to see a scan that's on the right-hand side where all of those gray smudges have disappeared. So the uptake in the tumor areas has been removed by some sort of treatment in this patient. So that would be what a complete response looks like on a PET scan. So I'm going to focus now on what is usually done for initial therapy for follicular lymphoma, upfront treatments. So despite sometimes kind of rushing to make a diagnosis and going through a lot of testing, patients with follicular lymphoma might arrive at the uncomfortable conclusion in the clinic that the initial treatment is actually going to be to do nothing, at least at the start. And why would we do that in a patient's got advanced cancer? So there are agreed upon criteria for initiating treatment for patients that have advanced stage disease, so patients with stage 3 and 4 follicular lymphoma. There's a couple of published criteria. This is from a French group called GELF, who did studies of together with other colleagues in the 80s and 90s. And so if patients have any of these criteria, low blood counts, a lot of enlarged lymph nodes, particularly bulky lymph nodes, more than 7 centimeters, enlargement of the spleen, fluid around the lungs or around freely flowing in the abdomen called ascites, or those constitutional symptoms that I talked about, those would all be considered to be reasons for treatment at the time of diagnosis. And the corollary is if none of those symptoms or features are present, then the recommendation is observation. So this strategy of immediate treatment versus observation has been tested in clinical trials 4 times over the last 30 years. Initially in the 80s with the comparison of very intensive chemotherapy, including a lot of radiation, to waiting until patients receive required therapy. So that's where watch and wait comes in. Prednisolone was a simple chemotherapy drug that was available in the last century, was compared to interferon versus observation by the GELF group. A large study, probably the largest study, was done in the UK using a single agent chlorambucil, an older chemotherapy drug given as a pill. And more recently, the same group compared the CD20 antibody rituximab to observation in patients with asymptomatic follicular lymphoma. And you can see that there is a difference in progression-free survival, disease control. If you give an active treatment, by and large, you're going to slow down the growth of lymphoma. But what all of these studies showed was that there was no difference in overall survival. So we weren't making people live longer by treating patients early. And therefore, the thought was, well, maybe we can defer treatment and defer the side effects of treatment until people really need to have it. So the median time, that is the time from up in which half of the patients have had progression and the other half are still progression-free in all of these trials, is about 3 years. In our published experience at Princess Margaret Hospital, it's more like 5 years. So there's a fairly good length of time between diagnosis and the need for treatment in the majority of people who have follicular lymphoma. But there are criteria, as I mentioned. You can't have any of the symptoms that were on that list of GELF criteria that I just showed you. There shouldn't be any sort of immediate organ-threatening lymphoma locations, including things like involvement of the liver, infiltration of the kidney, creation of fluid around the lung or in the abdomen. Those are all reasons why we would recommend treatment right up front. And then there's this other bar to pass, which is to ensure that the lymphoma stays stable. So in all of our patients, where the initial discussion leads to maybe we can just observe this for now, and the patient doesn't need treatment, we would invite them back for another set of images in 3 to 6 months, a repeat set of blood tests and a physical examination to be sure that what we are dealing with is a lymphoma that's remaining stable and not progressing. So all of the trials that I just showed you required this, that patients couldn't have had evidence of progressive disease shortly after diagnosis. So that we're picking the patients where this is actually the safest effective strategy. So if all of this checks out, and at 3 to 6 months, the patient is feeling well and the imaging looks good, then we embark on a period of observation. Again, a review in the clinic every 3 to 6 months, usually with some blood tests and a physical exam and imaging done to identify disease progression if needed based on what we hear from our patients. So there is a small group of patients who do benefit from immediate treatment, potentially with curative intent, and those are the ones who are patients who present with limited stage disease. So Ann Arbor stage 1, just one lymph node area, often it's a lump in the neck. Occasionally stage 2 disease. Those are patients that would be considered for potentially curative radiotherapy. So this does require staging by a PET scan, and it would require a bone marrow biopsy. A PET scan is not particularly sensitive for detecting very small populations of indolent lymphoma, so our radiation oncologists would want us to do a bone marrow test first. to be sure there's no marrow involvement. And if so, if all of that checks out and there's really just localized disease, particular stage 1, then radiation is recommended. Somewhere between 15 and 20 fractions, the usual curative dose that Princess Margaret is given over in small packages called fractions over a 4-week period of time. The side effects of this are really dependent on the location of the lump that's being radiated. So radiation is very focused these days, but sometimes side effects related to inclusion of normal structures in the radiation field can at least bring about some short-term side effects. This is a slide provided to me by a colleague at Sunnybrook that's actually evaluating or describing a radiation field for somebody with lymphoma in their sinus. And the blue areas are just the areas that are where the tumor volume is included. So it's very, very focused radiation these days compared to how it was given in the past, with a specific goal of excluding as much normal tissue as possible from the radiation field. This would be particularly important in this case, where the thing we're trying to avoid radiating is the eye and the optic nerve. So radiation is quite focused, and therapy and side effects of this therapy are really quite a bit less than we used to see in the past. If we're not going to use radiation and observation is not recommended for a patient, what's the next treatment option? What are the things we give for patients with advanced stage symptomatic follicular lymphoma? So I've listed 3 common chemotherapy combinations on this slide. The most common one is the one at the top, bendamustine and rituximab, which is given on a monthly basis for 6 months. Rituximab with cyclophosphamide, doxorubicin, vincristine, and prednisone, CHOP, a regimen that's been around longer than I've been a physician, is also commonly used, at least in some circumstances, in patients with follicular lymphoma. Less common than in the past, and I'll show you why in a minute. And then if we take the doxorubicin out of that, the recipe is called RCVP, and that was really the Canadian standard for many, many years until bendamustine came along in terms of the initial therapy for follicular lymphoma. There was a study that was done by a German group published in the early 2010s comparing R-CHOP to bendamustine and rituximab. And the response, although the response rates were fairly similar in this comparison, the complete response rate was a bit higher in patients who received bendamustine rather than the CHOP chemotherapy. But importantly, progression-free survival in patients with follicular lymphoma was much longer. So disease control with R-CHOP for 6 cycles was only about 3.5 years. But at the time of this publication, it was greater than 5 years in patients who received bendamustine. So this led to fairly prompt adoption of bendamustine as the first-line treatment in many countries, and in particular Canada. Not only did it improve progression-free survival, but the time that patients time elapsed before another treatment was needed was also improved. It's called time to next treatment. So there was a lot of benefit from this regimen. But in particular, as shown on this slide, it was a lot better tolerated. So the things that people worry about when they get doxorubicin are that their hair is going to fall out. That almost never happens with bendamustine. Infectious complications were less likely to happen when bendamustine was used. There was no peripheral neuropathy from vincristine, a common annoying side effect that patients experience when they're receiving R-CHOP. Mouth sores are left. So it was really the best of both worlds. A chemotherapy drug that all by itself with rituximab not only improved outcomes in terms of disease control, but also had less side effects. So it was really a kind of a win-win for the clinical trials seen in follicular lymphoma. So after people achieve remission, that is the state of having had a good response on a normal PET scan or a normal CT scan, how do we keep remission? How do we keep people in remission? So for a number of years, the use of rituximab all by itself, this important CD20 antibody that makes chemotherapy better when we combine it with chemo, is also very valuable when we just give it all by itself after the completion of chemotherapy. So other studies had been done in the second line setting, asking that question, could we maintain second remissions by adding doses of rituximab every couple of months or every 3 months? Those studies were affirmative, so this trial that's been published twice now was done as part of to ask the question about whether or not rituximab was useful as part of second-line treatment. So the induction treatment, the primary combination of rituximab and chemotherapy wasn't dictated by the study. Investigators could use whatever the local standard happened to be. But once patients had a complete or a partial response by CT scan, they were assigned to receiving rituximab every 2 months, given intravenously for 2 years, or simple observation. So it's a really large study. Over 1,000 people participated in it. And follow-up of this study now is greater than 7 years. So this is what the Kaplan-Meier curve comparison looks like. So remember when I showed you that earlier, that we want to see that these two things are separated, these two curves. So on the left-hand side is the progression-free survival curve. At the top in red, rituximab maintenance, and the bottom hatched line in blue. There's a big difference in progression-free survival between these two strategies. About 4 years worth of progression-free survival without rituximab, and almost 10 years progression-free survival with rituximab. So being able to keep patients away from the clinic and not needing therapy for an additional 5 or 6 years certainly seems like an important advantage, even though there's no improvement in overall survival with the addition of maintenance rituximab, and that is what is shown on the right-hand side. Excuse me. There's, at the time of follow-up at 9 years, there's no difference in overall survival. Most of the patients are still alive, even though relapses may have occurred. So we haven't improved survival, but we've provided significant benefit by the addition of maintenance rituximab, and it's fairly uniformly recommended for patients with follicular lymphoma. So is there a disadvantage to this? It looked like there was a pretty big advantage in terms of disease control. And the disadvantage really is infection. And I would say prior to the COVID pandemic, this was more of a theoretical concern than a real concern. We actually didn't see a lot of infections in the patients in receiving maintenance rituximab, although we know that their ability to fight off bacterial infections at least is somewhat impaired because rituximab reduces our ability to make antibodies. And that's really come to light during the COVID pandemic. So we witnessed at the very beginning much worse infections in patients who are receiving CD20 antibodies in general, in particular patients on maintenance treatment. Poor vaccine response is uniformly observed in patients receiving CD20 antibodies. In other words, people who can get vaccinated to COVID-19, but they don't respond well in terms of measurable response to antibodies. And we've even with the Omicron variants that are less virulent, less likely to land people in hospital, we've still seen patients with ongoing significant difficulties with lung infection who've had COVID. So our enthusiasm for rituximab maintenance was tempered a little bit during the COVID pandemic, especially in that first year when there was a lot of uncertainty about patient outcomes. And it's still a cautionary message with regard to the harms that could come from taking this ongoing maintenance treatment. Upside is longer remission. Downside is probably a significant increase in vulnerability to infections. And this is requiring a lot of discussion in our clinics about how to avoid COVID-19 in 2022. Well, what if things don't go as expected? I've painted a scenario where upfront treatment is fairly effective. Watch and wait serves many people well. They can defer treatment for 3 to 5 years at least. Local radiotherapy helps the 10 or 15% of patients who present with truly localized disease. What if primary therapy doesn't work so well? And unfortunately, there are some scenarios where that is the case. One is that we are now using PET scans at the end of induction treatment, so at the end of that 6 months of bendamustine and rituximab, to give us a better idea about remission status. And we've learned through a number of clinical trials, that including the PRIMA trial, that if patients don't have a complete metabolic response at the end of treatment on a PET scan, then the remission duration and the overall outcomes is actually a fair bit worse. Progression-free survival is worse, and in fact, overall survival is worse as well. So if we see patients who have a positive end of treatment PET scan, and that would be about 15% of the time, those are patients that I would follow much more closely in my clinic. We have them come back a little bit more often monitor closely for symptoms and growing lymph nodes. In my practice, I would usually repeat a PET scan a CT scan at least, in 3 to 6 months, just to make sure things are not growing quickly. And certainly if there's any progressive enlargement, a biopsy is warranted to rule out transformation. The other scenario is just overall early progression. So before the data on PET scans were available, it was observed that people who have progressive lymphoma within 2 years, within 24 months of commencement of treatment, also have worse outcomes. And this is probably basically the same population as the one that I just described to you. Worse overall survival and worse progression-free or worse overall survival was observed, and these are patients who need new treatment. But in particular, people with early progression within 24 months need to have a biopsy to rule out transformation. So we've seen this at Princess Margaret, and others have reported as well, that a large number of people with early disease progression, in particular the ones with progression right after chemo-immunotherapy and early on during maintenance treatment, probably have transformed lymphoma. They now have large B-cell lymphoma and no longer just follicular lymphoma. That happens at up to 3/4 of the time. And the last group are just those who are refractory to rituximab. So patients who are out on maintenance therapy, they're beyond that 24-month period, still receiving maintenance treatment or just finished it, and then the lymphoma comes back. We know that retreating patients with rituximab combined with chemotherapy in that situation is probably not going to be effective. The rituximab has probably exhausted its benefit. So there is another answer, though. There's another CD20 antibody called obinutuzumab, and that's been shown that together with chemotherapy, it can lead to improvement in progression-free survival. And at least in a study that defined this attribute of obinutuzumab, it actually can improve overall survival as well. So patients who still have follicular lymphoma that have this early progression or rituximab refractory lymphoma are candidates to receive obinutuzumab combined with chemotherapy. There aren't really data about the utility of obinutuzumab by itself, but so the recommendation would be obinutuzumab and chemotherapy for patients who have lymphoma that is refractory to rituximab. For some of the patients in the second and the third scenarios that I just described to you, so that's rituximab refractory or patients with early progression within 24 months, who don't have transformation to large B-cell lymphoma, we would recommend that they proceed to autologous stem cell transplant. It's not clear who actually is the greatest beneficiary of an autologous stem cell transplant with follicular lymphoma, but the consensus that has emerged is standard chemotherapy probably isn't going to produce long remissions. Novel therapies should be investigated in this patient population, but as one standard, an autologous stem cell transplant is considered, at least in my hospital, as something to discuss with patients. They have to be well, without a lot of comorbidities, good performance status, but that is a treatment that is considered in the scenario of early disease progression and refractoriness to a monoclonal antibody. So I've mentioned transformation a couple of times so far in my talk. What exactly is this? So we know that the longer a person has follicular lymphoma, at least a proportion of patients, the lymphoma changes. We know these cells that are dividing are acquiring genetic abnormalities or making mistakes when they reproduce themselves, and more genetic changes emerge with time. And they start to behave, these lymphomas start to behave like large B-cell lymphoma, the aggressive lymphoma that I mentioned at the very beginning of my talk. And on biopsy under the microscope to the pathologist, it looks like large B-cell lymphoma. The two are related. This is just a bad descendant, the evil cousin of the original follicular lymphoma cells. This happens about 2% per year if you look at a large population of patients with follicular lymphoma followed over time. Up to about 20 to 30% of people after 25 years will have experienced histologic transformation to large B-cell lymphoma. Upside is 75% of people never have this happen to them. We're more likely to identify this with early treatment failure, as I mentioned a couple of slides ago. The patients with very early progression after bendamustine and rituximab probably have transformation. And that really highlights the need for a biopsy. either an excisional lymph node biopsy or a core biopsy. We wouldn't make this diagnosis based just on a fine needle aspiration. That's where the pathologist or the radiologist put a small needle into a lymph node and just takes a few cells out. We wouldn't make this diagnosis based on clinical symptoms or blood test abnormalities. It requires repeat biopsy to demonstrate that transformation has taken place. And it also gives us, the pathologists, the clinicians and the pathologists, enough material to do extra testing to understand the biology a bit better and be able to counsel our patients in terms of what's the expected outcome. So the treatment for transformed lymphoma depends. There's many people where this is actually the first thing that happens during observation. Many years down the line, lymph nodes start to grow and a repeat biopsy shows large B-cell lymphoma. The standard for that patient population is to give rituximab together with CHOP. Bendamustine is probably not the choice at that point, and we would treat these patients like they had large B-cell lymphoma. If patients have previously had chemotherapy, and typically they've had bendamustine and rituximab, then alternative chemotherapy followed by an autologous stem cell transplant is the current recommendation. Just retreating patients with what they were treated in the first place, or just using R-CHOP alone in that scenario, prior exposure to chemotherapy is probably not going to produce durable remissions. So I'm going to conclude by saying, well, what's new in terms of follicular lymphoma treatment? Most of what I've talked about is the importance of decision-making around primary therapy. Are there new things coming along to make this the remissions even longer and maybe even cure follicular lymphoma? And I think I'll talk about that right at the end. So there are a number of new treatments that have been used. The ones that are on this slide are actually two drugs that have been approved by the US FDA and have achieved approval at least in Europe as well, idelalisib and tazemetostat. So idelalisib is a targeted agent. It inhibits an enzyme called PI3 kinase, which is an important enzyme in the growth of and development of B cells. It is sometimes mutated in patients with cancer, in particular lymphoma. And the response rate in the largest study of this orally active drug was about 50%. This is pretty good because these are patients that had previously had rituximab. Most of them are refractory, meaning they had progressed on their last treatment, and everybody had some kind of chemotherapy. And the remission duration in the study that got the drug approved in the US was about 11 months. So on average, people remained in remission nearly a year. The other figure of 7 months actually comes from a study from the UK where the response rate was quite similar in a similar patient population, but the duration of benefit was a bit shorter. Idelalisib is approved in Canada for the treatment of chronic lymphocytic leukemia, a relative of follicular lymphoma, and it's not approved for the treatment of follicular lymphoma, at least as yet. But this is an important class of drugs that are being explored in patients with follicular lymphoma that's not in remission after other treatments. Tazemetostat is relatively new. It comes from our greater understanding about the biology of many lymphomas, including follicular lymphoma. It inhibits an enzyme called EZH2, which is in charge of methylating DNA. So it adds methyl groups to DNA and turns off the transcription of genes that are important in cell growth. So it basically turns off some of the genes that are making the cells malignant. It seems to work better if the gene is mutated or is activated by mutation, which happens about a quarter of the time in follicular lymphoma. And the response rates in very heavily pretreated patients, pretty similar to the idelalisib group, it was quite good. It was nearly 70%, and long duration of disease control, 14 months, if there was an EZH2 mutation, but 11 months even if the mutation wasn't there. So we think this is also a promising drug. It's a pill that people take every day, and it's actually very well tolerated. We're waiting to see whether or not this will be approved at some point in Canada too. But much more new are strategies that I'm going to show you as I conclude that are really harnessing the immune system in follicular lymphoma. So the two things that are most exciting to us are these antibodies called bispecific antibodies and CAR T-cell therapy. So rituximab is an antibody. It just sticks to the outside of the cell and then passively waits for the immune system to come in and attack the tumor cell bispecific antibodies actually drag the immune system there by having a part to them that binds to the effector T cells. So if you look on the right-hand side, we can make an antibody against something on the tumor cell, and we can make an antibody against this protein called CD3 that's an activating protein on a T cell. And if we fuse them together, we can come up with a protein that actually brings T cells right to where the tumor cell is and then results in tumor cell killing. So there are a number of bispecific antibodies that have been developed in the lymphoma space. One of them is mosunetuzumab that has been approved by the US FDA just recently in patients with relapsed and refractory follicular lymphoma. The target is the same target, CD20, as with rituximab. And even though all of the patients in the trial that led to this approval had previously been treated with rituximab, the response rates were extremely high. The primary endpoint of this study of nearly 100 patients was complete response rate, and it was 54%. So while there's some technical challenges with regard to the administration of this drug in terms of supportive care, at least at the very beginning, this is mainly outpatient treatment, finite duration that seems to produce durable remissions, and we're waiting for this drug to be approved in Canada. We've done a lot of studies with this at Princess Margaret Hospital, incorporating it into combinations with chemotherapy. Seems to be a very fertile area of research, taking advantage of what we know about the immune system. And the other much more new therapy that is now coming to help patients with relapsed follicular lymphoma are CAR T cells. So there was recently a study of a construct called Axicell. We've been using this now for a couple of years in diffuse large B-cell lymphoma. But this was a study in patients with multiply relapsed follicular lymphoma. All of these patients in this trial had prior chemotherapy. They were all refractory to the last line of therapy, including rituximab. And this is not multiple infusions. This is just a single infusion of these things called CAR T cells, which resulted in a complete response rate of 74% and an overall response rate of over 90%. And these are fairly durable responses. So what is this? What's a CAR T cell? So again, this is the result of protein chemistry. So these people have taken the antibody binding part of an antibody. So that's the little bit of the protein in the box in the upper part of this picture. And they've taken that part and they fused it with the business end of the T cell antigen receptor. So this thing on the bottom is the protein that T cells use to recognize and act on foreign invaders, viruses, and tumor cells. So the business end of the T cell antigen receptor, the thing that really gets the cell to be activated and make more of itself, is fused with this, the business end of an antibody, and they make this chimeric antigen receptor. So the business end is still inside the cell, and the antibody binding part is on the outside of the cell. So technology exists to insert the gene for this whole protein into the patient's own T cells. And then the T cells are expanded and given back to the patient, and it fights cancer. So we take patients' T cells from their blood. They're shipped off to manufacturing facilities that right now are across the border in the US. There's 3 companies that now make these. The cells are engineered to express this chimeric antigen receptor, the CAR. They're cultured for a little while to make more of themselves, and then they're given back to the patient, just like a blood transfusion, except it's their blood. And therein is the 10 to 14 day admission period. We have to wait for the reaction of these cells to settle down. There's a thing called cytokine release syndrome, which is produced by the vigorous expansion of these cells once they get into the body and recognize the tumor cells. So there's some supportive care that's required for patients. The majority of patients now have to be admitted to hospital, but more and more we're becoming comfortable doing this as an outpatient at Princess Margaret. So exciting times for T cell therapy, or for immunotherapy in follicular lymphoma as well. Bispecific antibodies and T cell and chimeric antigen receptor T cells are going to become part of what we will routinely use for patients with relapse or refractory disease. So there's some other possibilities that might come to mind. We know that lenalidomide, a drug that's commonly used to treat multiple myeloma in Canada, is active in follicular lymphoma, and together with the CD20 antibody, whether it's obinutuzumab or rituximab, has produced durable remissions as well. More effective, the combination is more effective than either lenalidomide or rituximab alone. So the downside about lenalidomide is that it's not easily available. It's not approved in Canada for the treatment of lymphoma beyond multiple myeloma, but there are companies that are providing this, and access is available for some patients. This is a good choice. At the bottom, I'll just say that there's been a lot of interest in the immunotherapy arena in these antibodies that are directed against PD-1. Nivolumab and pembrolizumab are two that are approved for the treatment of Hodgkin lymphoma, a very distant relative of follicular lymphoma. Immunotherapy like this, PD-1 antibodies, has not been particularly successful in patients with follicular lymphoma. The response rates are fairly low, actually. So this may be one particular component of the immune system that's not immediately relevant for the therapy of follicular lymphoma, but research is continuing along these lines, looking at immunotherapy with antibodies, maybe just not these PD-1 antibodies. So I'm going to close now, and I thank you for your attention. Remission duration and survival of patients with follicular lymphoma, I think, has actually improved a lot in the last 20 years. When I first started in practice, median survival of patients with follicular lymphoma was 7 or 8 years, and now it's approaching 20. So this has been a product of a lot of research, a lot of carefully done clinical trials, a lot of science behind it. So is it better to have a curable lymphoma or an incurable lymphoma? I think if we stretch out remission duration, then we're starting to blur what the definition of cure really means. We have patients that are out 10 or 15 years having only had one prior line of therapy. As far as they can tell, as far as I can tell, they don't have lymphoma anymore. So practically speaking, who knows who's cured? I think we've achieved a lot, even if we continue to say that follicular lymphoma is not curable, but maybe it actually is. And I think we're really excited about the opportunities that our understanding of the immune system has provided us in terms of developing new therapies that are getting away from chemotherapy and harnessing our own immune systems to fight off cancer. That's particularly true in follicular lymphoma. So I'm going to close there, and I thank you for your attention, and I look forward to the question period.
Thank you, Dr. Crump, for your excellent presentation. We appreciate your excellent review of follicular lymphoma, detailing diagnosis, prognosis, and treatment options that are available for lymphoma patients across Canada. I'd now like to direct our audience members to attend the live Q&A session after this presentation. Thank you.